Thank you.
Thank you. A big hand clap for Olivia. I think one of the things that I must say, you're a great advocate because you're using evidence. You can hear she's quoting here and there, and I really admire you for that. Please keep working hard, and I think that's what can make you actually get quick wins in advocacy. Now, we're moving towards concluding our panel. I apologize to the audience that I won't be able to pick questions from you, but you can write them, we shall pick them, you can write and direct them to the panelists after. And I just want to give each of the panelists 1 minute to reflect from this conversation. What are we taking forward? Like, for example, I want to start with Honorable. Are we getting something in the floor of Parliament soon? What are the direction from all this conversation? What direction do you recommend us to take as the civil society, but also you as the legislative arm of government?
Thank you so much, and thank you, my fellow panelists. I want to say that there is a situation that is not good everywhere when it comes to health services. But I wanted us to appreciate the little that the government is putting forward. And I want to assure you that from the look of things, there is some light at the end of the tunnel. As a member of Parliamentary Health Committee, we have been going through supplementary budgets, and from what I have seen, there is a lot of requests in line with putting up, for example, district hospitals. There are so many districts that have not had district hospitals. I've seen them in budgets, and I believe within the next financial year, we are going to put up some hospital districts. I have seen budget in relation to increasing the number of health workers in the health sector, because it's all about increasing on the wage bill so that we have more health workers in health facilities, which is going to be a solution to her problem of having people, a number of health workers, much less than the people they really take care of. And I want to tell you that amidst all, whether government does what or what, there is what you and me are supposed to do. Especially sensitization of our people. Secondly, yesterday when I was going through some of these things, I look at what we call identity crisis. When it comes to youth, some youth are out there, they have grown without parents, without guardians, they are just lost. Who is going to guide them? It's me and you who already know what to do. We need to guide these youth from reckless behavior. What are we going to do? We need to talk to them in relation to mindset change. And it's civil society organizations that have the mandate to do this. Much as government is going to do what we are going to do, civil society organization, you have duty to talk to these people, you have duty to sensitize, you have duty to disseminate information to the public. And that is the reason why you're in place. Where government does not reach, civil society comes in. I beg to request each one of us to do the needful. Together, we can change Uganda to a better place for all of us, especially in sexual reproductive health and rights. Thank you.
Dr. Robert, just briefly.
Thank you so much. And just to summarize this one, I would like to mention that this should be everyone's business. It should not really be looked at as a, health. What is the Ministry of Health doing? The question is actually should be what is everyone doing? because the Ministry of Health, I'm pretty sure, alone cannot be able to resolve this. But if we really all work closely together, we'll probably get a long way in addressing all this. And just to put the issue of the family being the center of behavioral change, I think from the Honorable Minister and all of you will agree with me that I think there are very serious gaps in the families. And you know, it means even information is not getting to these young people at the family level. And of course, the cry of how can government now help us to get this information to these young people will also be a very difficult question to answer. If these young people are in our homes, like for us who are in this room, and they are not getting the information, and the question is, what is government doing to pass on information to these young people with whom we are staying? I think it also becomes very complicated. So that's really my bit of a parting shot, but the focus is really for us to work together. There's that saying, we are in this together, and so we should really think how best to get out of it. Thank you.
Thank you, Doctor. Olivia?
Thank you. I would give the following recommendations. One is we should abolish the push system to a system where health centers request for their own drugs, basing on their consumption to bridge the gap of drug stockouts. That is one. I think Minister of Health is here. Please, let's change that system. It can work and can help. We couldn't even be yearning to upgrade health center 3s to 4, if we can do that. The other is creation of youth-friendly service centers at health facilities. These people fear to come to hospitals because these nurses are all rude and all that. So if there is a special corner for them, of course they would run and get these services that they need. The other is we should urge our districts, the Bikwe district, to recruit more health workers, to bridge the gap, to reduce the cases of late coming, absenteeism, and the case of staff being overworked. The other is they should allocate a portion from the health sector budget to construct staff quarters for health workers, because most health workers complain that they don't have where to sleep, and that's why they cannot work over the weekend. That's where they come late, they open at noon, patients are there. So if these quarters are constructed for them, at least could help and could improve SRHR services that are being delivered to the community. Thank you.
Thank you. Thank you, Dr. David.
Yes, thank you. As we are beginning this session, you talked about values and experience. Yes, we as health workers have our values, but then there's also what we face as we do our work. One thing I have to bring out clear is that health workers fear the law, okay? So as long as the law is still as it is, old as it is, health workers will continue fearing working on some of the issues that face the young girls. So the law needs to be revived. Needs to be revised so that it can include some of the things, the rights and the policies that actually affect the young people who are affected with most of these complications. Then two, I also want to appreciate SEHAD about the comprehensive sexuality education, and I would encourage them to push forward. We as AWOGU, we are working on revising some of the curriculum of higher institutions of learning like universities. You know, if you come to the faith-based universities, there are some topics that are not talked about. Things to do with contraception in the Catholic-based institutions are not talked about. So we as AWOGU are working towards including some of these things in those curriculums such that things can be harmonized. And finally, I'll also want to add my voice on what Doctor said. We need to come back to the family. One indication that the family is dead is what has happened during COVID. The kids are home, but the unwanted pregnancies are on the high. Yet when they're at school, they were low. So we need to come back to the family And this has also been stressed by some of the religious leaders we've talked to about some of these issues. So we need to come back to the family model.
Thank you. Honorable, something burning?
Yeah, I wanted to say this, that it should not be a general blanket that nurses are rude. I want to assure you that some nurses are good, and they are doing a great work. You have seen them during COVID time. You have seen them when you go to some of these hospitals. So when we stand here and say that nurses are rude as a general blanket, it even demotivates those who are good. And sometimes it's not their own making. Someone comes completely with no gloves, with nothing, and she has come to deliver. What do you expect a nurse to do? Sometimes we need to work with them, talk to them, and we see how to solve some of these issues. But I want to assure you, nurses, midwives, and all other health workers outside there are doing a great job, and we really need to appreciate them where it is necessary. Thank you so much. That's what I wanted to say.
Thank you so much, Honorable, and the entire panel. I want to thank you for your great deliberation, and thank you, our dear audience. I think as we wrap up this, just to say that there's still issues of reality, policy versus reality. I think all this conversation really speaks to that. And us as the civil society and Honorable, you as the leaders, we still have to answer that question. What does that young girl do who is denied information, denied services, chased from home, chased from school? What does that young girl do? Because it is our responsibility as the duty bearers and this generation to protect the young generation. Thank you very much, and thank you, the audience.
I honestly think that they deserve a better round of applause than that. And also a special round of applause to the moderator, Mr. Charles Owekmeno, for the wonderful job that you've done. All right, I'll not waste time. We'll straight away delve into a presentation on the status of SRHR in Uganda, what the priorities are, progress, challenges, and solutions. We were meant to have Dr. Dina Nachiganda from the Ministry of Health delivering that presentation, but instead she has sent a very able representative in Dr. Justin Nabwire, who is going to do an equally fantastic job in delivering this presentation. Dr. you're most welcome. Can we give her a round of applause as she comes? Thank you.
Good afternoon. All protocol observed. My name is Nabwire Justin, and I work with the Division of Adolescent Health and School Health in the Ministry of Health. Sorry. Let's move on to the next slide, please. The next. Today I'm talking about the status of SRHR among adolescents in Uganda. And the Ugandan population, as we all know it, is basically composed of young people, with 75 being below the age of 19. And a third adolescents 10 to 19 years. That's a big population, and that's why we cannot afford to ignore adolescents. And of course, because of that, our young people are confused. They don't know how to deal with the changes that are happening to their bodies, to their hormones, but also the parents are confused. And they tend to call that, these kids are mad, or they are stubborn, they are impossible, but it is because of the changes. Adolescence on its own, of course, is a challenging phase, but was further complicated by COVID-19 pandemic, which thrust our young people out of school and into the community for a very long time, which had never happened. That became a challenge because parents had never lived with their children for so long, and young people were used to being in school, and school has, like it has been said, school is protective for our young people. Because as we saw it, when they came home, some of them were abused by the same parents who were supposed to protect them. Same parents or guardians, and then neighbors. So school is protective for young people, but as we have seen, it has been so long. The COVID-19 outbreak brought many changes, and we all know those changes that have affected our young people. I don't want to go into too much into that. We all know the increased teenage pregnancies. That's what everyone is talking about. So I want to continue and delve into the matter. What are our priorities for adolescent health? Because, by the way, this is priorities for adolescent health, basically. So our priorities for SRHR in adolescent health, top on our agenda is to reduce teenage pregnancy from, that was 25%, but now none of us knows. We could be at 50 or even worse. But our strategy was to reduce it to 14%, to fast track the approval of the ADH and school policies for implementation, to complete development of the ADH strategy, which is already in process, adolescent empowerment to enable participation in their programming. I'm glad to see that we have a number of young people here today, because many times we talk of adolescent participation, but when we are only older people, So, like it sounds a far-fetched thing, but today we have a number of young people around. Then community engagement, including parents and community gatekeepers. We cannot do this alone as health, because most of all of the issues that happen to adolescents, they happen in the community, they do not happen in the facilities. In the facilities, we only get finished products. So we want to reach the community where the problems are happening and see how to, but we cannot just get into the community without the community gatekeepers, these cultural leaders, religious leaders. Unless they agree to work with us, we cannot do anything. Reduction of HIV prevalence. You know, with pregnancy, we also have increased rates of HIV, because the route of administration is the same. The way someone gets pregnancy is basically the same way they get HIV. We have made some progress. Please, next slide. The previous one. Oh, sorry, the next. Next. So the ADH and SRHR policies are now waiting for top management approval. And then from there, they will go on to cabinet for approval as well. School policies at the costing level, and over 1,000 health workers in over 50 districts have been trained in adolescent responsive services, and we are still continuing. We take baby steps, but we are on it. Many health workers have been trained in adolescent responsive services. And actually, as the Honorable said here, it isn't right to just to generalize and say nurses are rude, because there are many health facilities which are very friendly to adolescents. Of course, I'll state a Lusoga saying which goes that entenda levu magani olugo. Just one person who does something wrong causes people to think that all, and you know how Ugandans we are, especially if it's a woman. You mistreat a woman here, she will go out and say, hey, abasawo bao. And it becomes all of them. Even the one who treated her well will not be remembered. Vaccination of teachers and students who are 18 years and above is ongoing. That gives us hope that our young people will be back in school soon and they will be protected. But we're also working with, we are working towards linking facilities, health facilities and schools, where health workers go into the schools and give information, SRHR information to adolescents. School reopening SOPs and surveillance system have been developed and pre-tested for compliance and feasibility. We have trained police and other community leaders in GBV. We thought that, we realized that just training the health workers won't help, because these cases happen in the community. So we needed the police. Actually, in some districts, the police have already started community policing, where they go with health workers into the communities and teach the communities about GBV, about the crimes. Some people commit these crimes not knowing. They think if a 14-year-old came and asked my brother and said, can I go and cook for you? And it's just because she's the one who has brought herself, it's okay to have her. And because of that, we have very many young men who have gone to prison. Very many young people, and their future will never be the same. But those are also adolescents. By the way, when we talk about adolescents, we are not only talking about girls, we're also talking about boys. We have developed, we have established district committees on adolescent health in about 50 districts, and we are still we want to reach all the districts in the country, but this is also cascaded down to reach sub-counties, because we want to have committees right from the sub-counties where issues come from down upwards, not coordination coming from up downwards. But if it comes from down, because they know the issues are happening in the community, not at the national level. We have developed a standardized adolescent health age appropriate information package, plus IEC materials in 23 local languages. Adolescent empowerment and participation is on track through peer education programs that are supported by our partners. Here we recruit some adolescents to work with the health workers, with the health facilities, but it's mostly funded by partners, not by government. We have availability of some electronic and virtual platforms for consultation. We have a national call center where adolescents call in, and we have been having many of them call in to ask, they tell you they have been, maybe they were raped, they ask about family planning, they ask about all kinds of issues, and we are encouraging many of them to take this up. So these are the various platforms. Some are supported by partners. Sorry, next slide, next, thank you. Through our work, of course, we are faced with many challenges. Many adolescents are HIV positive, but also it is hard for them to take medicines. I don't know how many of us here can easily take medicines. For me, many times I find it hard to finish a dose of azithromycin. Those are just 3 tablets, 1 in a day. So, I can understand them, but again, what can we do? Those are the medicines we have so far, and we want them alive. So, it is hard. And many times the parents of these HIV-infected adolescents are not involved. I worked in an HIV center some years back. And you would find a 10-year-old coming alone, a 9-year-old, 8-year-old coming alone to pick their medicines. Then they'll pick the medicines and keep them. We have increasing rates of gender-based violence in homes and communities, cross-generational sex and transaction sex, which is high risk, with high-risk groups, poor involvement of parents and communities, delays in policy approvals, limited access to SRHR commodities, information and services during lockdowns, limited community support to access health services, especially SRHR, substance use among adolescents and young people, which predisposes them to risky behavior, inappropriate exposure to non-adolescent friendly content through social media and mass media, high school dropout rates. Multi-sectoral approach is not easy to implement because each sector has its own mandate and they want to follow their own mandate. So though we want to work together, it is not easy to implement. There is high risk of sexual interactions due to limited activity at home, increased cases of defilement, excessive amounts of time spent on social, have we repeated? Then there is limited funding, of course. What are our next steps? We want to employ, we are employing, and we are continuing to do this, to employ more community approaches in SRHR information provision. Where are we going to the community? We can no longer wait for adolescents to come to the facilities because they don't usually come, since actually they don't, most adolescents don't fall sick. Increased adolescent participation in programming, updating of pre-service training curricula to include adolescent health, multi-sectoral approach and coordination, bottom-to-up coordination of adolescent health through DICAs and SICAs, utilization of mass media and digital platforms, health facility school linkages to foster SRHR information access to students, data-informed interventions, improved availability of commodities and supplies across the board, parental engagement, male empowerment and engagement, we have empowered girls, but we have left the boys behind. And then the disempowered boys come and disempower the girls. And then we go back to square zero. Then we need to conduct ADH targeted research. Thank you very much.
Thank you so much, Dr. Nabwire. Do we have quick reactions from the young people in the house? Yes, I'll have John Jesse. I guess so, in the interest of time.
DICAS, this is District Committee on Adolescent Health. I happen to be on one, which is really non-functional, because the only meeting we had was the orientation meeting. How do these DICAS report back to ministry? I would like you to. Those are my concerns.
Thank you so much. One final one. Yes, the gentleman.
Well, thank you very much, Doctor. Final, I've been given a chance, though. Okay. In your presentation, Doctor, it was very insightful. You actually highlighted about what the ministry has done and what is expected to be done, and it was really informative. But my concern is, just like you highlighted that very many, or actually, there's the way you highlighted that most of the people, rather young people, cover the biggest population of this mighty republic. And we cover almost 70 and above %. You mentioned about quite a number of things that the ministry is looking up to, the priorities, the challenges, and all that. We as young people, we look at this in a perspective that almost each and every great thing is done by young people, one. Two, we look at it in a way that at a certain point in time, we are less represented, more so when it comes to purposes of policy and decision-making processes. I mean, we are not included, and it doesn't bring out the issue of meaningful, inclusive youth participation in all these processes. And guess what? At the end of the day, all right. At the end of the day, the policies, the decisions that actually are made at the top level of management in various sectors, as to be specific, the health sector, are going to be implemented or are going to affect the young people the most, due to the fact that we cover the biggest percentage of this mighty republic. So my question is, or my concern is, I understand you might not be the final decision maker in this courtesy, but it is a prayer to the entire ministry. Good enough we have the legislators in-house, in their absentia, but it's also crucial that we as the young people at least appear in such processes, most of the policy-making processes and decision-making, such that all the processes and decisions come out to be effective at implementation level. When my sister Olivia was presenting, it was actually from the bottom of her heart, because she is at the grassroots. She knows what is happening that side. That's why Charles Owekmino, the executive director of the SRHR Alliance, comes out and he says, this is actually policy versus what? Policies versus what? Policy versus reality. And ideally, and I also believe that it is actually words versus actions. So there's a lot of planning and all that. The framework is actually good. By the way, these frameworks and policies are good, but when you look at the implementation, oh my God. And guess what? We, the young people seated in this house, representing various young people outside there, are going to suffer the more. And we are suffering the more. It is my humble appeal to the legislators in the house, the policy makers, oh my God, CSOs and all that, stakeholders, that let us prioritize young people. Let us include them in all processes of change, because I believe if given a platform, young people have the capacity and audacity to do more and even change everything as regards to sexual reproductive health and rights of young people and vulnerable adolescents in the country. Thank you.
Clearly, you can see the young man is heading towards the political side of things. But it's good to see an empowered young person. Daktari, as you respond to the question that was posed by my brother, John Jesse, and you will also respond to, I don't know whether it was the response that was given by the politician. Kindly pass the microphone.
I just forgot one thing. My name is Hakim Kayonga, a youth researcher with Restless Development and a member of the Youth Advisory Committee at the SRHR Alliance of Uganda. Thank you.
We hope you make it to Parliament, sir. Daktari.
Thank you for the questions, the concerns, the comments. For reports, getting reports. Okay. Feedback to where? Where? Yeah, but then there must be a platform. Should we just, I don't know if it is, are you organized somewhere that we can send reports there? Or maybe on social media? Community health, social media. Okay, I'll take that as a feedback. But there must be something organized where reports are sent, or like a date that may be, or such a gathering that we are coming to share the reports to the what? To the young people. Because you cannot just wake up and say, and as you know that for Ministry of Health, for us we are resource limited. So yeah, so we cannot organize, it is not, usually there are days when they are, yes, Dr. Mutumba. A particular report.
But I think there are so many forums where reports are being disseminated. I
During,
to understand which particular report we are not.
feedback.
So there are so many forums where reports are shared. And I think that's why my colleague has also been struggling to understand which report doesn't get shared.
Okay, I think the young people are just sharing feedback. Let's take that in good stride.
For the DICAs are supposed to report to ministry as in biannually, twice a year. If you say your DICA is non-functional, I'll need to take that, and so that we check on that DICA. For the inclusion, we have really included young people, at least in ADH policy formation. We have included young people through, most of the times we invite these, the SRHR Alliance, and they are the ones who invite the young people to participate. We do not go out on our own to call the various young people from their communities. But the CSOs and CBOs, they invite young people. We are not talking about old people, but young people. And they have participated in the formulation of the ADH policy. So I hope that can rest your fears.
All right. All right, thank you, Daktari. And for that conversation to continue, good enough, you're sharing a table. The deliberations can continue over tea, which we shall have after the next session. So we are going to move to the last session of the day. And it comes on a background of the jazz program aspirations of having an SRHR movement that is bold, that stands and advocates for sexual and reproductive health and rights. And to take us through this discussion, I'll invite Ms. Dorothy Amoron. Ms. Dorothy Amoron is the Program Manager of Campaigns, Partnerships and Networks at the Center for Health, Human Rights and Development, who will in turn invite her different panelists. You're most welcome, Dorothy. Let's give her a round of applause.
Thank you, Jordan, for that wonderful introduction. I know that we're all tired. It's been a long day. You've really been overbearing. So without wasting much time, I'd like to invite our lovely panelists who form part of the Jazz Advocacy Program to join me at the forefront. And then I'll go by the names of the organizations. AMWA, Rahu, UNESCO shall be represented online. And then we'll have HIRAF and then HAPES. I'm calling out these names intentionally in the CSO jargon language for a reason. Thank you. Could we take up our seats? We have a representative from HIRAF. I think I saw him around. UNESCO, we have Ms. Mujuni. I hope she's online. And then finally, HEP. So we are fully constituted. We just have regrets from NAFOPANO. They are currently engaged in another meeting, but just to say that they are part of this program called the Joint Advocacy for Sexual Reproductive Health and Rights. We've heard about movement building. So when we talk about the jazz program, we always talk about the jazz, but we've never painted a picture of who is behind this program. We talked about national partners that are implementing this together with the broader sexual reproductive health rights movement. And so this is the opportunity we get today to actually paint a picture or a face to the national partners that are helping us reach out to the numerous districts that we are operating in. You're very welcome. So we'll start from the extreme. HIRAF, kindly tell us what HIRAF is, and the thematic area generally under this program, and what the last 2 years have been of implementing this program for you. Thank you.
Thank you. Thank you so much. My name is Edward Mwebaza. I work with Human Rights Awareness and Promotion Forum. So that is what HIRAF is. We do human rights advocacy and for especially marginalized groups and most at-risk populations in Uganda. And we do legal aid service provision. We provide advocacy, and then we also do a lot of empowerment, community capacity strengthening. So under the JAS program, we have been championing interventions under the cluster of refugees and sexual minorities. And we have been, first of all, addressing violence. And we do address sexual gender-based violence for refugees in the BDBD refugee settlement, as well as Koboko and Yumbe districts. And we also do provide a lot of legal response to violations of key populations in that case. We have engaged a number of duty bearers, especially for refugees, and we've come across a lot of violence that young girls and women in the refugee settings face. And all of these intertwine with a lot of issues to do with the law and issues to do with ignorance that people have been talking about here. And you're creating awareness on their rights and what they need to do in case of those violations that happen, but also engaging duty bearers within, first of all, the settlement, but also within the districts generally to work together with the refugee girls and women to address these particular issues. We are also addressing issues of violence related to that key populations suffer. And we are finding, of course, many people have been talking about the issues of the law and hindrances that are basically stopping service providers from providing these particular services. So we find that the law is one of the things that are limiting programming, but also delivery of services and also information to these different communities. So we engage with the communities themselves and create awareness on the rights, and we ensure that they can demand for these particular services. So I think the year has been good, and we think that the integration of these services, but also the advocacy that communities are bringing together is a very beautiful occurrence under the JUST program. So they are addressing the question of leaving no one behind and making sure that we bring all communities together. Because in the quest for human rights, you have to be very deliberate to make sure that every Ugandan is included. That if services are being provided, then every Ugandan has the right to access those particular services. If they are not being reached, that means that we are not using a human rights-based approach to SRHR. Thank you.
Okay, thank you so much, Edward. Today we've learned about HIRF and what they do, what they stand for, and the critical role that they play in advancing sexual reproductive health rights for all. Thank you so much, Edward. Since it's been a male voice, I'd like to mix up, so I'll take it right to Amwa. Thank you. Is it working?
I don't think it's working. I hope this is working. Okay. Thank you so much, Dorothy. Thank you, everybody, for being here until this time. I know it's not easy. It's a Friday, but we have all made it here. That means that we are so committed to what we're all doing around SRHR. My name is Gloria Mugabe. I work with Akina Mama wa Africa in the Sexual Reproductive Health and Rights program. A little bit about Akina Mama wa Africa. We are a Pan-African feminist organization that ensures that all our programming is deeply rooted in feminist principles, borrowing from a feminist charter of African feminists. So our work looks at dismantling systems and questioning structures that have caused us oppression, all of us, in our identities, but more so women, girls, and gender-expansive persons. Our work spans across over 7 countries, but I'll focus today on Uganda, and we are focusing on 3 programs, and that is sexual reproductive health and rights, women in political leadership, economic justice, and climate action. And today, I am here because we are part of the JUST program, and our contribution to the JUST program is ensuring that our approaches and our advocacy is informed from a feminist perspective, and that looks at not just providing approaches, advocacy initiatives, but also looking at the systems and structures that have caused us to be here in the first place, looking at the fact that we do not want to leave anyone behind, regardless of gender, identity, sexual orientation, and also age. So our approach is very intersectional in that regard, and we'll continue to push for that. So what we have achieved under JUST over time, we have ensured that we have moved away from just human rights approaches. We have continuously fought for rights, right? We have continuously advocated for change. We have continuously advocated for better policies and legal framework around SRHR. But we're also questioning what are all these other contributions to our SRHR issues? Why don't we have, why aren't people enjoying the SRHR? So we have moved into health financing campaign, looking at the fact that SRHR is an issue. It's also a funding issue. It's because SRHR is not funded. So we have continuously done health campaigning. We have We have done work around the budget advocacy through having trainings for people to understand really what are the allocations that go to the different SRHR needs, but also to just keep writing and producing documentation of our lived realities in regards of health financing in this country. Through JAZZ program, we have also provided trainings from SRHR perspective, understanding that not everybody in the consortium is on the same level, and we're all here to learn and hopefully be better and build our society. So what we do is we provide our trainings from an SRHR perspective, looking at, again, the systems of oppressions and structures and why is it that women and girls don't have sexual freedom, for example. So looking at issues around bodily autonomy that has been denied from women, looking at power imbalances that we have been talking about since morning. So our work is very, very holistic in that regard. And it is hinged on three main pillars. That is through policy and advocate and movement building, policy influencing and movement building, through feminist development leadership trainings, like I've mentioned, and also through feminist research and documentation. Okay. So that is what we do, and a lot more other things that we will get to know about.
Thank you so much, Gloria. I know that I'm taking your marathon, but we don't want to exhaust the participants' patience too, and also the fact that we're still maintaining SOPs and observing these issues. So I'll invite the next panelist, and that is from HAPES, to share briefly what HAPES has been up to and how they feed into the joint advocacy for sexual reproductive health rights under the program. Thank you.
Thank you, moderator. Good afternoon, ladies and gentlemen. I'm happy to be part of this.
Could you use the mic? Because we also have online participants. They could miss out.
Thank you, moderator. I am Robert Ofiti. I work with HEPS Uganda, which we know as Coalition for Health Promotion and Social Development. We exist to ensure equitable access to quality health services and socio-economic empowerment of Ugandans. And we do that through health policy advocacy, particularly with the specific bias on access to essential medicines in the country, but also do community empowerment, where we do programming through sensitizing Ugandans on rights and health responsibilities. And so we are happy to be part of this conversation today. And we thank SEHAD with our singular donors, SIDA, for having made this possible. You asked how what has been going up and about in HEPS Uganda. HEPS on the partnership of joint advocacy for SRH in Uganda, which is JAZZ program. Our thematic area is to look at ensuring access to SRH commodities. You know, every aspect in health of people comes to finally an equation where medicines are needed to make health okay. And so access to essential medicines is a matter. Essential medicine simply means that at every facility, basic medicines that can take care of preventive ailments can be healed. That's why they're called essential. At any one time, they should be available, depending on the essential medicines and health supplies list per level of health facility. And so for SRH commodities, as HEPS Uganda, the first thing we are doing is to work with JAZZ partners to see and hear the voices of what stakeholders in Uganda say about availability of medicines in public health facilities. And for HEPS Uganda, we are in the district of Lira and Kiboga, but the JAZZ program covers 14 districts. And so
we coordinate the program on issues concerning availability of SRH commodities in public health facilities. And so just to bring forth a few things that we have worked together is to enable districts where we work be in position to hold meetings for ordering medicines in case they are out of stock. Stockouts have dimensions. Are they within facilities at district level or at national level? And so at the district level, when there are stockouts, for example, there is a redistribution between sister organizations. But also there are emergency orders where the DHO, with her or his in charges, can have a meeting to say what are our needs in medicine. And so as CSOs in the health sector, particularly those who provide SRH commodities, sit together and plan to address the needs. And so HEPS has been at that to support meetings of DHOs, ensure that emergency orders are placed to NMS.
Okay.
Yes.
Are we summarizing?
That is part of what we do.
Okay.
But in organizing and building a social movement that addresses underlying obstacles to realization of SRH rights in Uganda, we have also held coalition building meetings. We have built 2 coalitions in 2 districts of about 45 CSOs and NGOs. And these meet on a quarterly basis to address issues concerning SRH, but of course with the dimension of access to essential medicines. But also, in that regard, we have also been able to come up with innovations to track and support government efforts. We have also been able to conduct community dialogues. Community dialogues at sub-county level bring up the voices of the young persons, of the adolescents, of women and men, but also other vulnerable groups of people who are finding it difficult to access SRH services, but also specifically access to SRH commodities. And so there are a number of voices, a number of conversations going on, but for now, I beg to submit that. Thank you.
Okay, thank you so much, Robert, for bringing to light what HEPS is up to. We all know that access to medicines is an issue that touches all of us because accessibility is an issue that we have to keep struggling for or advocating for right from the grassroots. Thank you so much, Robert, for that presentation or highlight of what you've been up to under the JAZZ program. Allow me now invite somebody that we always call this organization Rahu, and when we hear Rahu, it's about young voices. Sheila, kindly take us on. Thank you.
Thank you so much, Dorothy. My name is Sheila Kasabiti. I work with Reach a Hand Uganda, the youth organization. Reach a Hand Uganda is an organization that is mainly focused on making sure that the young people in our communities are empowered with the knowledge that they need, specifically speaking in regards of SRHR knowledge that they can use to make adequate decisions regarding their lives. And through this, we have ensured that many of the districts that we are working in, these young people are able to access information in terms of SRHR, able to work with the different people in their communities to be able to make the right decisions for their futures, as we have been clearly seeing from the previous presentations where we have all been talking about and have been able to see the high teenage pregnancies that are arising in our country. It's really alarming. And Reach a Hand Uganda has been able to contribute and is continuing to contribute to the knowledge of young people for them to ensure that they continue to be empowered and knowledgeable, knowing their rights, knowing the policies that they can use to back up in case they need any information or they are denied access to certain services. So as Reach a Hand Uganda, we continue to ensure that we try to reach out to all the young people in Uganda, in the rural areas where most people may not try to focus in. And you may have looked at the statistics of like the teenage pregnancies where most of them are coming from the rural areas. And these are areas that we have been probably ignoring and not providing those young people with the adequate information that they need. So this is where Richer Hand Uganda comes in, because we are focused on ensuring that young people in their full diversities are given all the information that they need to make that adequate decision in their lives, to know that if I'm to have sex, this is the consequence of having sex. I will get pregnant or I'll get HIV/AIDS. So if a young person is not empowered enough to be given that information at a young age, because we have even seen those who are getting pregnant as young as 10 years old. So we are there to ensure we reach the young people in the depth of all the districts in Uganda, and we see how we can be able to help them and work with the government and all our coalition partners and other organizations that are fighting the same vice in the country, to see that we do not see this becoming a recurring habit in our country. And then apart from that, also we do a lot of livelihood and skilling programs for our young people. We have a very interesting academy called the Peer Educator Academy, and I think we have been able to hear some of our voices, like Fahad, who is in the audience. Yeah, some of our voices, some of our key young people who are our foot soldiers out there trying to ensure that their fellow young people are able to continue making the right decisions in their lives.
Well, thank you so much. With and for young people definitely is a way to go, because it starts from, the upbringing and at a certain particular age. So thank you so much for taking on youthful issues to the forefront. Basically, the Joint Advocacy for Sexual Reproductive Health Rights Program is bringing different organizations with different niches to work together to ensure that we achieve sexual reproductive health rights for everybody, inclusivity and all. I just want to ask, and feel free, not sure if Miss Naomi Mujoni is online. Naomi, are you there? UNESCO? Kindly introduce yourself. Okay, so in the interest of time, I am going to have to pause a bit. We've not had a chance to hear from Naomi. Hopefully she will catch up with us if time allows. It's just interesting. I just want to find out from the panelists what the added advantages are in voicing out sexual reproductive health rights collectively, because we know some of these issues are contested issues. We talked about issues to do with access to comprehensive reproductive rights like abortion rights, and there was a debate on some of these things. So what is your take? Are there added advantages to working or voicing these issues collectively? Feel free to take on anybody from the panel.
There are advantages that come in synergies in such a partnership. For example, from what we've learned together in the JUST program, we've been able to appreciate that the young persons have been facing challenges, but maybe platforms to express them in accessing SRH services are few or limited in terms of representation. But when
please, I'm not sure if everyone is able to hear
the
submissions.
But when we go to this program, we discover that young persons are many and diverse. They have many needs, but specifically to access to SRH services, we have learned to appreciate that even when it comes to accessing medicines for SRH, there is still a big gap. For fear of stigma, for example, in communities, they are either limited to go to seek them because they fear what the families, what the communities will say. But also on the other side of the health service provision, there is that judgment. You have also come for this.
Okay.
And so those gaps are even increasing vulnerability of young persons in seeking health services, particularly SRH, because of stigma around family, around community. But when we come together through such conversations, we learn from each other how to perhaps work with so and so who is good in dealing with young persons.
Okay.
They motivate you, give you approaches which you integrate in your programming in communities, for example. But I think we need also to put a difference. When we talk of communities, it's not only people in up-country rural areas, but even in urban areas, we have communities of the young, but the needs are the same. Medicine is the same. And so this coming together helps us appreciate that, to support a big group of people.
Thank you so much, Robert. I think what's also important that is outstanding is that it's created a reflective and supportive space where we borrow from each other modules and also benchmark on each other's niches to ensure that we address the different components of sexual reproductive health rights at all levels. Very insightful. Yes, any additional learning?
Yes, thank you, Dorothy. I was just going to start with what you just said, so now I have to find something else. But it's very true that through the JAZZ program, we have come into a space where we can learn and unlearn, which is very critical. Before we go out there, before we start changing policymakers, before we start changing systems and duty bearers, we have to learn some of these things ourselves and learn and unlearn the biases that we hold because of our upbringing, because of our culture settings and our context. So what JAZZ program does is that it brings us closer to do that. When Akina Mama of Africa is holding a training on feminist transformational leadership, we are all going to benefit. When Rahul has an event around inclusion of young people and meaningful engagement of young persons, we're all going to learn. It's not just the outsiders that are learning or the beneficiaries, but even us, we're changing our mindsets. The program has a representation of sex worker-led organization, queer-led organization, feminist organization, persons living with HIV organization. So bringing those different perspectives within the consortium itself, I think it's a very powerful thing that we have all benefited from. And I just want to say that as we go on, as we continue implementing the program, it's upon us to also continuously push our learning limits, because I think we sometimes get too comfortable. But learning that intersectionality is not, for example, just representation, just having a young person, just having a sex worker on your panel. It's going deeper and looking at the systems and structures that have continuously inhibited access to spaces of these communities, looking at the systems of power and how they feed into each other and how can we continuously dismantle them. I like that our overall program goal is around building a progressive social movement that boldly challenges these systems. So it's something that we have to continuously take with ourselves as we implement.
Okay, thank you so much. Hiraf, any challenge so far?
Okay, you've changed the question, but yeah, but thank you. I just wanted to add on the earlier question about coming together.
Yes.
For me, I think there is power in a collective voice, that if you're fragmented and asking for the same thing, it might not be heard.
Okay.
But it just provides an opportunity where all of us are going to send the same voice to the people that have the power and the responsibility to fulfill those particular needs, so that they are not bored with so many people shouting.
Okay.
If you are in a group of people and everyone is asking for something, you may not hear what they are saying.
Okay.
But if they all say, let us say this, and you hear only one voice, then you actually find it very, very easy to deal with. So in terms of challenges, I think we still have a lot of, from our perspective, we still have a lot of ignorance about issues of SRHR, but also about issues of diversity.
Okay.
So we exist in a country where we are so many groups, types of groups, and there's a lot of ignorance about the SRHR needs of the different groups, and some of the groups are being left behind in that case. And what happens is that you think you are providing a service, but you are ending up leaving out certain groups of people.
Okay.
And then we are also having an issue of the laws. The laws are very good things for us to exist within society, but also they need to be developed in such a way that they are cognizant of the fact that we are a democracy and we are using a human rights-based approach, so that they don't, instead of promoting rights, end up actually becoming a barrier to achieving those particular rights. So I think in most respects, you saw, for example, I was listening to this particular dialogue over Zoom, and I had a person from the Ministry of Health here coming and saying, abortion is illegal. You know, that is a very blanket, thing that you can say about abortion is illegal, because when you go deep into the law of Uganda to dissect it on abortion, you find that it's not outrightly illegal. So, and we did a study about the enforcement of abortion laws, for example, and we found that the way the law is enforced is actually creating challenges for health service providers to provide the services that are within the law, even on abortion itself.
Yeah.
So all of those are challenges that we find when we are trying to demand that these services be available and accessible to every Ugandan. Thank you.
Okay. Yeah. Thank you so much. There's power in collective voicing, but most importantly, when you have the same message, the impact is felt. And again, dealing with the different diversities, because sexual reproductive health rights are broad, and just mapping out who is relevant and who is not, and just ensuring that you don't leave anybody behind is a very tricky and complex issue that is food for thought for all of us. Thank you so much. Naomi, I'm aware that you're online. UNESCO?
Hello, good evening, everyone. Yeah, I'm Naomi Mjuni, and I work with and for Uganda Network of Sex Work-Led Organization, that is abbreviated as UNESCO. And we are an umbrella organization that brings together all sex work-led organizations across the country, mandated to bring all sex work for a common or collective voice to advocate for all the issues that affect sex workers in all their diversities. So UNESCO is also one of the partners under the JUST program, and our thematic area is sex work, and we do contribute to most of the JUST program objectives and goals. And just under JUST program, we do implement it in 2 districts, that is Gulu and Busia, but we also have other projects that are nationwide. But also at a national level, we do work with the JUST partners to implement several activities or interventions that do promote SRHR for all. So to be specific, as you may all know that the SRHR is limited in the country in terms of availability and accessibility, and also due to the stigma and the fear that is associated to accessing the service. But one may wonder what happens when it comes to the already stigmatized, discriminated, unaccepted, but more so a criminalized community like sex workers. You understand that sex workers are already severely stigmatized population, and more so they extremely experience adverse SRHR outcomes because of the way they live, leading to unintended pregnancies, high exposure to STIs. We all know that the HIV prevalence is more high among the sex workers compared to the general population, but also currently there is an increase in sexual and gender-based violence against sex workers.
Okay, yeah, Naomi, in the interest of time, I'm just going to ask in just a minute for you, what would be your call to action in terms of what kind of support when it comes to advocating for, issues that are deemed to be illegal within the country? What are your thoughts in terms of what can be done to improve such advocacy?
Okay, thank you, Dorothy, for the question. But my call or my recommendation may be like, as long as there are still laws and policies that have or contain those problematic clauses that criminalize sex work, that criminalize HIV and other public health issues, that means that the realization of SHIV in Uganda may remain minimal. So there is need to amend the policies or the laws that criminalizes sex work, but also HIV and other public issues. And another call would be like strength.
Finally?
Hello?
Hello, yes, we can hear
Finally,
you. Yes.
There is always power into community empowerment. I think every speaker has spoken about community empowerment, but it needs to be more inclusive. When you were introducing UNESCO, you talked about being inclusivity. And I really commend JUST program for being inclusive, that now you also have, we have a thematic area that represents sex workers, but let it be in all other programs, and more so economic empowerment for the affected community, because we shall come as human rights defenders, as SRHR advocates, but strongly to advocate for the desired change. But when the affected community is not fully empowered to demand for own rights or do not know their rights, really, the problem shall still remain.
Okay, thank you so much. Again, it goes around policy friendly environment to ensure that nobody is left behind and is criminalized. Finally, to Rahul, what has been that one lesson so far in the 2 years of implementation that you leave the audience with in terms of the joint advocacy for sexual reproductive health rights? What stood out for you in the journey of advancing sexual reproductive health rights for young people?
One of the key things, first of all, I'd like to commend the JUST program for providing that opportunity to facilitate a process that is more transparent. And in the process of being transparent, we are all accountable to the communities in which we work in, or accountable to the young people we work for. So in the years of implementation, we as Rahu we've met the challenge of COVID. COVID has been a big challenge for us, and I believe for all other organizations. But through that challenge, we have had a lot of innovation around that. Because we knew that in order to reach out to young people, we had to get innovative, not to go into the lockdown and let the situation get serious or worse. So through those innovations, we have had innovations like through the media campaigns. We had a media campaign that was for End Maternity Death that enabled, for example, young people in Kasese district to be recognized that they are having issues in terms of young people. For example, young people in Kasese are having, like, how can I call it, transactional sex? They're having sex for pads. A young girl will go out not willing to sell her body, but because she knows at the end of the month she has a period and she does not have pads for that. So she has to go through that process, which is not something that we want our young people to go through. And that was one of the innovations. Other innovations were looking at making sure that our media, all our media stakeholders are able to speak the same language in terms of SRHR. And through that, we may have been locked down in terms of having dialogues like what we are having now. So we had to innovate and make sure we are having online dialogues where we are able to make sure that media is able to communicate the right language.
Okay.
Not communicate SRHR, young people are getting pregnant, but young people are being raped, because that is actually the right language that should be put out there.
Okay.
Then the least but not the last innovation was to make sure that young people are being involved. This is through the peer educators that we have on ground, making sure that the young people on ground are able to reach their nearest neighbor, not only looking at them going to the next districts. No, look at your nearest neighbor. How can you help the young person next to you by giving them the right information that they need in order for them to make a well-informed decision in regards to their SRHR health?
Okay, thank you so much. I think the takeaway was transactional sex, and this is a call to parents. Things are not obvious to everybody, so while you're shopping in the shopping malls, make sure that sanitary towels or pads are probably part of your commodity list to ensure that we don't lure the young girls into transactional sex, but also reminding our stakeholders, even the government, that there are certain commodities that should be prioritized nationally. Periods are natural, and therefore they come in and they don't know your pocket. So while we budget under sexual reproductive health rights, we should be also looking at commodities like pads to ensure that we prevent a lot of, first of all, unwanted pregnancies, diseases, but also to ensure that the young people are empowered to access school, for example, whenever they open, without fear that they'll soil or be embarrassed. Just to say thank you so much for your patience. I know you're itching to say so much, but we have to conclude this session, and I just want to thank the participants for overly being bearing. We have the community health advocates from the different districts, again, very pertinent parties that have helped us achieve, the programs under JAS. Thank you so much for your patience. And just to say that you're part of the movement. Ms. Fatia in the morning said there are 6 national partners, 7, including SEHAD, but you are part of the movement too. So your patience here clearly shows that you value the work that the program stands for. And so please do not tire whenever we call upon you to make your contributions. Thank you so much for being a wonderful audience. I know you're tired, and hopefully we'll engage more in the future.
Thank you so much, Dorothy, and I think Dorothy and her panel deserve a better round of applause. Thank you. All right, so we have reached the evening hours of our dialogue, and we'll be having closing remarks from a gentleman called Moses Liagoba, Assistant District Health Officer for Kamuli District. But before I call upon him, I wanted to make a few announcements. Firstly, in terms of logistical announcements, if you've not signed on one of those mobile wallet forms, kindly approach the table at the back so that we do not miss you out in terms of your facilitation for attending the meeting. Secondly, we have tea that is ready, but in case you're running late, I think there's a provision for you to pack the tea and take it home. Then lastly, but by no means least, wanted to say thank you to all of you for making the time to attend this dialogue. But we also wanted to say special shout outs to our sign language interpreters for the day. I think they deserve a good, it's better you do this. It's better you do this. Wanted to say thank you to Mr. Wycliffe Bukenya. Thank you so much. I wanted to see how he translates his name. Okay. Also, Miss Olivia Nachigozi Bulega, you most thank you so much. And let's do this one more time for them. All right. But also, lastly, but by no means least, the overall moderator for the day has done an amazing job. And I think it's only important that we give him a thunderous round of applause for doing an amazing job. Thank you. Thank you. Happy to serve. Thank you so much for being an amazing crowd. I would like to invite Moses, kindly come and give us closing remarks, and then we will run away. Thank you.
Yeah, thank you so much, moderator. Good evening, everyone. My name is Liagoba Moses. I'm the Assistant DHO in charge of maternal and child health of Kamuli. Let me take this opportunity to thank Sihud for organizing this dialogue. It has been a wonderful one. Thank you so much. I would also like to thank Minister of Health, Dr. Oral, Dr. Mongahi, and Dr. Nachiganda represented for blessing and attending this dialogue, because rarely do we find high-profile dignitaries to such dialogues. But it has been a wonderful event, and we thank Minister of Health for really standing with us, because we always get energized when we see you around. Yeah, I would also like to thank the presenters, the moderators, and the panelists for the wonderful job well done. It has been a wonderful day, and we appreciate all the processes that we have gone through. I only want to say one thing. Districts are the end users of sexual reproductive health services. And in the districts, there are people responsible for sexual reproductive activities, the assistant DHOs in charge of maternal and child health. I kindly request our IPs, our funders, to work with and exploit the assistant DHOs, because they are very key, and they are struggling because they are implementing some of these activities without money, but they are just motivated to do their work. So our IPs kindly request that you extend a hand to that section to improve the youth. I know the youth are agitated, but once we improve on the leadership at district level, we are going to achieve our objectives. I don't want to waste a lot of time. Time is not our best ally, and it's getting late. I would like to thank everyone for attending and for being patient up to this time. I kindly request the Almighty God to give us and accord us journey masses back home for God and my country. Thank you.
Yes, that means the meeting is officially closed, and we will venture into the other side of business. So again, if you've not signed for your transport facilitation, kindly approach the table at the back and see the SEHAD team, who have done an amazing job organizing this dialogue. And yes, we'll see you again next year as we organize, hopefully, the third annual national dialogue. And when we approach you, kindly do the same. Thank you.